Good evening and welcome to UOA On Demand. My name is William Baione. I'm a board certified orthopedic surgeon specializing in joint replacement and adult reconstruction. I have the pleasure of being joined today by my partners, Dr. Stephen Kayiaros and Dr. David Harwood, to discuss the topic of knee osteoarthritis and total knee replacement. Arthritis is a condition that affects a large proportion of the population. Total knee replacement has become a very common procedure. And as the American population and the worldwide population ages, you're seeing an enormous growth in this procedure and how often it's performed. Here's a slide that shows a projection of primary total hip and knee replacements from the early 2000s up into the years 2030. And you can see that there is a very large number in the growth of these procedures. One of the things that you can see when you look at these types of replacements is that there is a growth in the age demographic of people that are receiving these procedures. You can see that a procedure like total knee replacement that historically was done on older patients is now being offered to a larger proportion of younger patients, those that may be in their late 40s up to their early 60s. So my question to my colleagues is, why do you guys think this is? And as we get into our discussion about joint replacement, we can cover some of the treatment options that we offer patients before we talk about actual surgery.
I think it's probably multifactorial. I think, in general, people are more active, engage in a lot of activities, a lot of sports, and over time, that can lead to wear and tear of our joints, particularly our knees, since the knee is the largest joint in the body, and it does withstand a lot of stresses just from everyday activity. So I think that's one factor. I think another factor is that, we do have an obesity epidemic here in our country. And so we know that that is a risk factor for arthritis, more weight on the joint. Our joints were not designed to withstand that much weight. And so that is a factor in leading to end-stage arthritis. And I also think that the technology in knee replacement over the last 40 to 50 years has come a long way, so that before, a knee replacement would maybe only last 10 years, and so patients would really put it off until it was really, really bad, basically until they were almost disabled before they had surgery. Whereas now a knee replacement should last maybe 25, 30 years. And so people are not really waiting as long to get the surgery. So I think, those three factors, I think, have contributed to the surge that we've seen in the last 20 years on knee replacement.
Dr. Harwood, so when a patient comes to see you and they may be a candidate for a knee replacement, but they're a little bit afraid of surgery and they want to try some things that don't include surgery, what options do you offer them?
So patients come with a variety of experience prior to seeing us. So oftentimes they've already been given some other treatment options by their primary care physician or even another orthopedist. And oftentimes they just come for the first time to see me. So it runs the gamut. But the routine treatments for arthritis are really based on their symptoms. So it's not that you're going to reverse the arthritis or going to prevent it from getting worse, but what you're looking to do is alleviating some of their symptoms. So the activities or the pain levels that they have are now back to a level where they can live their lives without surgery. And so the usual things a lot of people try on their own, like anti-inflammatory agents. So over the counter, there are options like Aleve or Advil. Now, those options are not without potential risks as well. So people that are thinking about taking some of those medicines, I would caution them to be careful with their stomachs, with their blood pressure, run it by their medical doctors. Activity modification can be okay if the patients are comfortable enough to eliminate some of the activities that are the most symptomatic. So if they have some activity that bothers them and they're able to live without it, then that's an easy fix in the beginning. There are other things that are more aggressive and a little more invasive. So we have shots. A lot of the patients are really interested in shots. And the two basic categories that we offer, there are other categories which we can talk about later, but the two basic ones are cortisone shots and viscose supplementation, or what most people call gel shots. So the cortisone is an anti-inflammatory agent that I offer patients mostly for flare-up. So they have some pain, but they're doing okay, and then all of a sudden they have a flare-up, and the x-rays aren't really different, but they're in more inflammation and more pain. So that's a good time to do a cortisone shot to get the knee back down to the level it was at baseline. Or occasionally somebody will have an activity like a wedding or some trip that they want to feel temporarily better. So that's a good thing for a cortisone shot. And then the viscose supplementation or gel shots are more of a long-term solution for those symptoms. I wish I could tell patients that it's a guaranteed benefit, but it seems to me most patients, it's about the 60 to 70% of them will get some relief, and they can get it for up to 6 months or even longer. And if they do get relief, then we can actually repeat those shots in 6 months. So those are the more invasive things. So another option, especially for patients who have become less active, is physical therapy. So that's certainly not invasive, and it can tone up muscles and change gait and things that become bad habits that can contribute to the pain, and the therapist can help work with that to get it back up to baseline again. And it's always a good thing to tone your muscles anyway. And then again, what Dr. Kayiaros had alluded to earlier, it's a difficult thing to bring up to patients because we're not really judgmental as orthopedists, but it's a simple fact that the force on the knee joint is what causes the pain. So in many activities, the force on the knee joint is 3 times your body weight. And so if patient is overweight, a really, really good thing to do is to lose some weight. And it doesn't have to be 100 pounds, but if it's 3 times your body weight, if you think about it, if you lost 10 pounds, that's 30 pounds of force every time you did one of these activities. So that's a really, really good thing to do. And then there's other nutritional things that patients have said that they take some anti-inflammatory herbs like turmeric or glucosamine. None of that's been scientifically proven, but often patients do tell me it helps, and it's certainly not, it doesn't cause any harm. So those are the basic tenets of pre-surgical treatments.
Dr. Kayiaros, when a patient asks you about some supplemental treatments, a topic that often comes up is, how do you feel about stem cells or PRP or platelet-rich plasma for the treatment of osteoarthritis? How do you counsel those patients?
I tell those patients that we just don't really have good research to show that stem cells or platelet-rich plasma injections really has any potential therapeutic benefit in the setting of arthritis. I think the American Association for Hip and Knee Surgeons came out with a position statement on these injections, saying that for severe end-stage arthritis of the hip or the knee, there's no role for those injections at all. For early arthritis, their position is that there could be some benefit, but again, there's a gap between in the science of what platelet-rich plasma and stem cells could do to in the setting of osteoarthritis. So I tell them that insurance doesn't cover it. There's a big out-of-pocket expense. They're not really burning any bridges, so to speak, but they shouldn't expect, they really shouldn't have high expectations that those treatments are going to result in significant benefit.
So now you have a patient that you've seen, you think they meet criteria for joint replacement. I think one of the things that you run into when you talk about joint replacement and specifically knee replacements is that there is a proportion of patients that you could have a successful operation, but they may not be happy with the outcome. And one of the things that I find is that it's very important to gauge not only their symptoms, but their expectations and what they expect to get out of the joint replacement. And so when you're selecting a patient or you're indicating them for surgery, what are the things that you present to the patient in terms of what a joint replacement, specifically a knee replacement, can offer them, and in terms of what they'll be able to do, what they won't be able to do, and things like that?
Well, I think there's two different types of expectations. One is a functional expectation. So if a runner comes to me and is still not decided that he wants to or she wants to give up running, and they are limited in those activities because of the pain in their knee, and they want a knee replacement to get back to those activities, it would be disappointing if they got their knee replaced and then I said to them, well, you're not really supposed to run because knee replacements are not designed for impact activities. Now, having said that, there are some running type of activities in a mild way that we usually let patients do, like mild tennis and that sort of thing. Or pickleball is like a big thing these days, so that's perfectly fine. Pickleball is great, actually. So I would say, that's a good reason to do it. The other categories that patients are disappointed are there's some limitations just in terms of the pain relief that knee replacement surgery can offer. The replacement surgery is really for the arthritis pain, and it doesn't guarantee that the knee will be painless after the surgery. It's just it will get rid of the arthritis pain, but there are other reasons that patients can have pain. And so in my practice, the two major categories of complaints that patients have after knee replacements that may allude to disappointment would be the difficulty in kneeling. So it's not necessarily prohibited, but there will be a scar in the front of the knee, and that scar can be sensitive and often is. So if the patient has a particular activity such as gardening or some other even professions like carpet laying or various other activity or occupations, they may be disappointed in the fact that their knee still hurts when they kneel on the knee. And then the second major category of pain that people have, even though it's not an arthritic pain, but there's a lot of strain on the muscles that extend the knee in general. And then after the knee replacement, those strains are still there. And again, it gets back to the weight. So 3 times your body weight go across your extensor mechanism, which is really part of your muscular system. And it doesn't help to have a scar in it as well. So often patients still have some discomfort on going up and down the stairs. And so that is another, it's not prohibited, but they can still have discomfort, and they're often surprised that they have any discomfort because, that's why we did the knee replacement. So those kind of activities, I really tell patients up front that, beware that this isn't going to potentially solve all of your problems, but those are mostly what it's limited to. And the final category is not often, but occasionally patients will have been either on their own or given or by pain management been given narcotics and for chronic pain, and then eventually they get their knee done and you expect all the pain to go away. but those patients tend to be sensitive for a long, long time. So it's been proven that people who are on relatively heavy duty pain medicine pre-op have a much rougher time post-op and tend to be more disappointed.
I think those are excellent points. I often counsel patients that the real reason to do the operation essentially should be pain. You have radiographic arthritis, you've failed conservative treatment, and you have pain that affects your quality of life. The patient who is otherwise relatively active, still walks several miles a day, plays in sports activities, and feels limited at times. In my experience, that patient often is very functional. So what a knee replacement offers usually doesn't line up with some of the limitations they may have. And so I think that's an important discussion to have with patients. You have to be honest with them because you don't want to have that discussion after the surgery, because then it brings into question whether or not they actually needed the procedure. So I think counseling is important. I think one thing that will aid our discussion today for the audience is to actually talk about what a knee replacement is. So Dr. Kayiaros, I have a visual aid up for you. And often when I'm in the office, I will have a few models and things available to help describe the procedure to patients. And so if you can kind of talk us through that, how you would explain what a knee replacement is to a patient.
Yeah, this is actually a really great diagram, because it shows that, obviously it shows the implant, what it looks like and what we do on the inside, but it illustrates that we're not really replacing the knee. And so when I talk to patients about what a knee replacement is, I tell them that it's more of like a resurfacing procedure. So we basically we keep all the anatomy, we remove the arthritis, so we shave off the ends of the bones in the knee, the tibia, the femur, and the patella, the kneecap. And we sculpt trim the edges of the bones to match the implant. And then the ends of the bones are capped with the implant. And the analogy that I use is that it's like capping a bad tooth. And so there's two metal pieces that get attached to the bones, and then there's plastic in between, and the shape of the implant mimics the shape of the knee. And so we keep the ligaments on the outer part of the knee, we keep the quad muscle, the tendon. And that's essentially what the procedure consists of.
Thank you. I think Dr. Harwood, you earlier alluded to the narcotic pain medication and maybe patients that were on these medications prior to surgery. So now that we kind of went over the diagram, what exactly we're doing, I think one thing that will help the audience is kind of understanding the recovery or what the perioperative course is for this procedure. And so a patient will often come in and they may have had a friend or a family member or someone that lives in their community who's had the procedure. And I'll often hear some type of horror story about, oh, it was so painful and they said you should never do it, or they did it once and they wouldn't do the other side. So when you hear these things, what are the things that you say to patients to help guide them in terms of what to expect and how we go about managing the pain?
So, first of all, I would reiterate exactly what you and Dr. Kayiaros just said. It's that, a total knee replacement is really a bad name for it. So whether it's a psychological advantage or not, I think people are more comforted and have less of an expectation that this is going to be a horrific procedure, just knowing that we're not going to, some people think we chopped in mid-thigh and mid-shin, remove it, throw in the garbage, and then put this device on. So just knowing that that isn't the case, I think is psychologically helpful to them. But on the other hand, we do have to make an incision or a cut in the skin and the soft tissues, which does hurt. So the biggest challenge is to reduce that the pain level that they have postoperatively without using a large amount of narcotics. And we used to use just large amount of narcotics, and what would happen is that the patients would suffer a lot of the side effects of the narcotics and still not have the benefit of the functional relief that they could have potentially given. For example, if they have to go to physical therapy, it's hard to do physical therapy because it hurts. But if they're given large amounts of narcotics, it hurts less, but then it's harder for them to participate in the therapy. And then they get the side effects from the narcotics, which is constipation, nausea, vomiting, and that sort of stuff. So all of us have gone to what we call a multimodal pain management system. So we give a lot of different things. Each individual thing isn't enough to solve the pain problem by itself, but it's also not large enough to cause too many side effects. But in conjunction with everything, it's a pretty good system to give a decent amount of pain relief, at least enough for the patient to be functional and not in an extreme amount of pain. And so some of these elements are pain medicine that is relatively fewer risk factors, such as an anti-inflammatory. So there are some anti-inflammatories that don't have the stomach issues that the ones that over the counter do. And also they don't have some of the effects of thinning the blood, which can cause bleeding. So that's, a very good thing to add. We have Tylenol that we give patients ahead of time or tell them to take. We have some nerve medicines that also contribute to reducing the pain level. And we all use in the OR injections into the tissues with some anesthetics, such as what a dentist would use if they were going to work on your teeth. But the ones we use in the OR are even longer acting than what a dentist would use. So the patients can get relief up to 24 hours, which isn't obviously the total post-op course, but the first 24 hours are arguably the most painful. So we eliminate a lot of the worst pain in the beginning. And so the patients don't have this pain expectation right off the bat. And then the final thing, which I think most people use now, and is certainly part of my practice, is we get our anesthesia colleagues to help us by putting some sort of a nerve block in. So pain is relayed to your brain by a nerve or by nerves. And so if we can numb the nerves that conduct this pain signal, then we can reduce the amount of pain the patient feels and the amount of pain that requires narcotics as well. So in at least in my case, and I think you gentlemen use it as well, but you can speak for yourself. But there's a nerve in the thigh that the anesthesiologist will put a catheter in, and the catheter will release some anesthetic, just like again the dentist would use, a very small amount, but constantly on a continuous drip, and it continues for 3 to 4 days post-op. And the other nice thing about this system is that it's portable. So the system delivers this pain medicine over the course of 3 or 4 days, and the patient can go home with it. And then when the reservoir of the pain medicine is empty, then it can just be removed very easily by the patient. And again, it's not going to be for the whole post-operative course, but it's for the first few days, which are the worst days for pain. And the result is that the patients are able not only to take fewer pain medicine, fewer narcotics, but they're able to participate in physical therapy better. And the biggest goal for any patient in the first month post-op is to get your range of motion. And it seems easy, it's certainly easy to understand, but it's difficult to do because the knee is swollen and sore. And right when the knee is the most swollen and sore, you're telling the patient to bend the knee and straighten it. And so these multimodal techniques will allow patients to do that early, and then they don't get into trouble later with stiff knees.
Great. I think I'm going to present a case now just to kind of guide the discussion, and then we'll talk a bit about a few other things. So I'll pull up the slide So here I have a set of plain radiographs or x-rays of a patient that presents with bilateral knee pain. This patient presented to me with a few years of treatment, combination of her primary doctor as well as some other orthopedic surgeons. She is 72 years old. She has pain in both of her knees, pain with daily activity. Has done multiple rounds of injections, and essentially came in and had asked about whether she was a candidate for knee replacement. And so based on her x-rays and a failure of conservative treatment, we indicated her for surgery. So Dr. Kayiaros, when you are talking someone through the operation, how would you describe your perioperative course? Like what for them, what they would expect in terms of how the hospitalization goes? Dr. Harwood touched on the pain management, but patients often want to know like how quickly they'll recover. And so what's a typical time frame for you?
So typically I tell patients that the surgery itself will take about an hour and a half. Once the anesthetic has worn off, they'll be up, they'll be walking later that day with a physical therapist, depending on their age and their pre-operative functional status. Patients can either go home the same day or spend one night in the hospital. And usually most patients, if they spend a night in the hospital, they'll go home the following day. Physical therapy will be set up to come to the house for a few weeks until patients can transition to outpatient physical therapy. By a month after the surgery, most patients can expect to be walking comfortably, maybe a cane for support. Most patients by 3 months after the surgery can expect to feel as though they're seeing the light at the end of the tunnel. Anecdotally, patients have told me after the fact that 6 months after the surgery is when the knee felt really good and they felt like, the recovery was, pretty much fully complete.
Thank you, Steve. Here I have this particular patient's postoperative radiographs. The recovery you described is pretty typical for most patients. The patient was able to go home the next day. She used the multimodal pain. She progressed her physical therapy. I saw her at 6 weeks, and she basically said that her left knee felt great, but that her right knee was killing her. And you can see here on the x-rays, here's this nice straight leg that previously was crooked or in varus, where we've resurfaced the ends of the bone. And here on the other side, she has this very arthritic knee. And so one of the topics that often comes up when you evaluate patients is that you don't walk on one leg. And so sometimes you have arthritis in both of your knees. And so patients will often ask, am I a candidate to have both knees done? And they'll ask for a recommendation about that. So Dr. Harwood, how do you counsel a patient about that? Or how do you decide whether or not you think bilateral knee surgery is a good option for a patient?
So that's a really good question, and a question that's often asked by patients. It is a very difficult recovery for the patient to have both of the knees done at the same time. The results in the long run are great for knee replacement, but in the short run, they're more painful than the arthritic knee. So for the first few weeks, the patients would have both of them done literally don't have a good leg to stand on. And it requires much more assistance. Oftentimes, these patients would require admission to a rehab center, which is difficult for the patient and the patient's family. It's also in this day and age, especially not ideal. If patient needs pain medicine, it takes longer for them to get it at a rehab center than if they're home. The infection rate is higher when they go to rehab centers. So it's not impossible, but I would prefer that the patients recover in the safety and cleanliness of their own home. And it's much easier to do it with just one knee. The other thing is about the pain management systems that we talked about earlier. It's much easier to do one of the catheters than two catheters running at the same time. So we can manage the pain of one knee way better than they can then we can manage it with both knees. And there is a slightly higher health risk to patients, because it's not like taking your car, to the shop where you have a muffler that has a hole in it and your tires are bald. So you get them both changed. It's one easy trip, and then, it's great. You get it all fixed. Well, everything you do to the human body, however, has a cost. It's a trauma. Surgery is a trauma, and so every trauma the body has to recover from. So when you do two knees, it's two traumas, two recoveries, slightly more dangerous. Especially for older folks, I would very much try to talk them out of it. Rare exception is a very healthy patient who is working, and we assess the risks and the benefits and decide that it's safe enough to do both of them at the same time, and that way they wouldn't be out of work for too long. But again, those are less common in my practice than having patients do just one. And if we do just one, I'd like them to be recovered from that one before we talk about doing the other one. So for me, it's usually at least 3 months, but it can be any time after that. So patients can decide to do one knee and then a year later do the other knee or whatever. But at that point, they're in the driver's seat. It's not my decision, it's theirs, which is a good thing for patients to have control over that.
Thank you. I'd like to guide the discussion now to some of the other questions that come up when it relates to knee replacements. So with the amount of surgeries that are being done, there sometimes are complications that patients can run into. So Dr. Kayiaros, what do you tell people about what the possible complications are for knee replacement and things to expect that could potentially go wrong?
Sure, it's a good question. So for knee replacement surgery, like any surgery, the usual risks, there's risk of infection, there's risk of damage to neurovascular structures or nerves, veins, arteries. We put all patients on a mild blood thinner after the surgery to help prevent the blood clot. As Dr. Harwood said, surgery is a trauma to the body, and so there's potential risk of a health issue or a medical problem after the surgery. So I talk about those risks, and then inherent to knee replacement surgery, it is a mechanical implant. It's not like what we were born with, and so there is a potential finite lifespan to it. There's potential for loosening and mechanical issues or wearing away, but as we discussed earlier, the technology of knee replacements has really come a long way, and so the manufacturing of the devices that we're using now has dramatically changed, and so a lot of the problems that we saw earlier with knee replacements, such as bone loss and loosening of the implants, is not as prevalent of a problem anymore, and that speaks to how good the implants are. And so we can confidently tell patients that a knee replacement should and can last, well beyond 25 years, as long as the surgery itself is done, correctly in the first place. I think one of the potential risks that I spend a little bit more time talking about with patients is, the risk of stiffness. And so that's a little bit of a black box. There's a lot of risk factors that we know that can play into that. But I think talking to patients ahead of time and prepping them that even though the surgery will only take an hour and a half, the recovery is long, and the patients are doing the hard part of the recovery following a knee replacement, going to physical therapy, doing their exercises, regaining their motion. And so I think it behooves us to talk about that with patients, because if patients develop stiffness or they don't regain their motion, that could be a problem, because now they're in pain, they have a stiff leg, they're not meeting their goals, and then that could potentially lead them to needing an intervention, such as like a manipulation. But I think that those are kind of like the things that I like to highlight.
Those are all great points. you touched a little bit on technology, and I think there's been definitely a lot of advancement in the replacements themselves, the biomaterials, the plastics that we use that now last so many years. Something that I think is a product of today's age with information and direct to consumer marketing. Patients will often come in with questions about technology and how it's used during joint replacement and specifically knee replacement. So three topics that typically come up that patients want to know about, what I think about them, whether I use it or not, are things such as computer navigation, robot assisted surgery, or something called patient specific instrumentation. So Dr. Harwood, what's your experience with those technologies? And is there a role for it? And if you do decide to use it, if you could explain, in a very basic way, what those things mean for patients in terms of knee replacement.
Sure, that's a really good question, and I get that question a lot as well. I think that the goal as a surgeon when we do knee replacements is to put the implants in the best position possible for that patient, and that will ensure the patient the longevity of the implant. So if you don't put the implants in the proper position, it can compromise the future of the implant and the knee. So that's the goal. And no matter what technology that you choose to achieve that goal, as long as you achieve that goal, it really doesn't matter that much which one of those or none of the above that you use. So the of the three that you mentioned, I actually do use the computer assisted surgery where I bring the computer into the operating room, and we have the computer sort of with our pointing out specific landmarks tell us like where the cuts and what angles we should make. The patient match system, it does the same thing, but it requires an MRI ahead of time, and then the MRI is then uploaded into a computer which rebuilds the patient's knee, pre-op knee, on the computer, and then we actually do the virtual surgery on the computer. And again, the same angles and sizing and whatever that we would do in the OR with the computer assisted stuff. And the robotic surgery has gotten a lot of press and there a lot of marketing, and I think it's great. There's nothing wrong with it, but it's also it's a means to an end, and it's expensive, and a lot of times hospitals will spend a lot for the device, and then they feel obligated to get their money back when they market it, and so they bill it as maybe a little more important than it really is. So I think all of those techniques are great, but even our original, not original, but more are instruments that were developed prior to these new techniques are just about as good, and I don't think there's anything wrong with it because the goal is the same. I personally use those techniques. It's a little esoteric and in the weeds, because it allows me not to put a hole in one of the bones that tends to bleed a little more, so I get a little less blood loss. But for the most part, I don't really think it matters, as long as the goal is achieved. And whatever the surgeon feels comfortable with, I think that's entirely appropriate. And I wouldn't pick one or the other based upon a technique that an individual surgeon uses.
Thank you. That was a great explanation. I have a question for you, Dr. Kayiaros. I wouldn't really call this technology, but another option when it comes to knee replacement that comes up is the topic of partial knee replacement. Do you think there's a role for that type of replacement? And if you're selecting a patient, how do you decide if they're a good candidate for a partial knee replacement versus a total knee replacement?
Yeah, that's a good question. I do think that there is a role for partial knee replacement surgery. I think there are, the knee is the largest joint in the body, and it has, kind of three compartments or 3 rooms, so to speak. So a lot of the times, most patients that get arthritis in the knee, it kind of starts in one compartment. Depending on how long they've had it for, it can spread to the other compartments. But a lot of times there are some patients where it's just kind of localized to one compartment. And so in those instances, if it's localized and patients localize their pain to that part of the knee, I think those patients are ideal candidates for partial knee replacements. Compared to total knee replacements, it is less invasive. The recovery is a little bit quicker, but they're technically more demanding. There's less room for error. You really got to get it from a technical standpoint. You've really got to get it perfect. A total knee replacement, there's a little bit more forgiving in the sense that you're replacing or you're resurfacing the whole joint, then you're balancing the whole knee. And so if there's some bone loss, or if there's something's a little off, well, you can make adjustments and you can sort of correct things to get to where you need to be. But with partial knee replacement, it's a little bit different. And so I do think from that regard, that the demanding part of it being in the technical demand part of it makes it such that it's just a little bit harder. Percentage wise, I tend to really go by the strict criteria for who is a candidate for knee replacement. And so if you go by those strict criteria, it's not a big percentage. In my practice, it's probably about 10% of the knees that I do are partial knee replacements. I think you can certainly expand it and do more partial knees depending on the types of patients that you see in your practice and how comfortable you are with the procedure. But I think if in a well-selected patient with localized disease, I think a partial knee does great.
Great. Yeah, I think that's a similar proportion in my practice as well. I'm pretty strict with my criteria. But some patients come in interested in that. And, what I often tell them is, if you have a partial problem, then a partial solution is good. But if it's more than that, then, you're going to provide incomplete relief. And some patients don't like the idea of that, the fear that somehow the rest of the knee can go on to develop arthritis and the potential need another operation. And so even if they're a candidate for a partial, if they're of the opinion that they would rather do something more definitive and minimize their risk that they could develop arthritis, I try to involve the patient in the decision-making. I'd like to thank my colleagues for joining me today for this discussion. I think we hit on a lot of pertinent topics that are important to patients that have osteoarthritis. We covered the gamut of total knee replacement. If you are a patient out there and you're having pain in your knee, you think you may be a candidate for a joint replacement, or you're just looking for an evaluation, the surgeons here at UOA, we're all fellowship trained in joint replacement surgery. Whether you want us to evaluate you for a possible knee replacement, or if you have a knee replacement and you're just looking to see if anything's wrong with it, or if you're having a problem, please feel free to reach out to us. You can visit our website at uoanj.com. Thank you for joining us tonight on UOA On Demand.